Thank you for watching this program tonight with the best physicians of the region. My name is Dr. Luis Munoz, and I'm the president of the El Paso County Medical Society. It is our hope that you will find this program informative and interesting. We at the El Paso County Medical Society invest in community education with our programs. I hope you will find this program very informative, with great medical advices and great medical information. Thank you again for watching this program tonight, and have a great night.
El Paso now has a pediatric comprehensive multi-specialty center that can service all of our region. This means that children with complex conditions are able to see their specialists all at one time and all at one place, rather than waiting weeks or sometimes months for each separate condition. And most importantly, families no longer have to leave town for the lots of specialty treatments that they may need. So how exactly does this level of care impact the landscape of our pediatric healthcare in El Paso? And what are some of the new types of specialists we have here, as well as what are some of the new lines of service now being provided here in our region? All that and more coming right up. This evening's program is underwritten by the El Paso Children's Hospital, and we also want to thank the El Paso County Medical Society for bringing the doctors to you and this program to you every single month. Good evening, I'm Catherine Berg, and this is the El Paso Physician. Thanks again for joining us. Tonight we're going to be talking about specialty in pediatrics and what exactly is El Paso and our region able to offer now. I'm super excited to introduce to you a married couple, and they did promise that there's going to be a lot of banter this evening, so this should be a lot of fun. But with us tonight, we have Dr. Jonathan Chaio and Dr. Amanda Chaio. Dr. Jonathan Chaio specializes in ear, nose, and throat with pediatrics, and he is with, obviously, the El Paso Children's Hospital, and he is a fellow trained head neck surgeon, so he's going to have all those questions of surgery coming your way. And Dr. Amanda Chaio is a person who's an allied health member. She kind of helps everything that's going on in the surgical world, and she's an audiologist. What exactly is that? We'll find out from her. And she's with the El Paso Children's Hospital and also the Texas Tech Paul L. Foster School of Medicine. So thank you so much for being here. We've had a lot of fun over the last 20 minutes just creating our own banter and figuring out what we're going to be talking about. So thanks for being here. Amanda, since you're the wife and you're the girl, you get to start, and also because you're on my right-hand side. That's how it always works here. But for people who don't know what a doctor in audiology is, in pediatric audiology, how would you describe that to our audience?
Sure. So an audiologist, our entry level is a doctoral level. So we come in at a doctorate level, and our intention is to serve a lot of different disciplines. So certainly, ENT is probably the majority, but we also serve other specialties, including craniofacial, pediatricians, hem-onc oncology. And our role is really to diagnose hearing loss. I'm a pediatric audiologist, which means I specialize only in children. We're not necessarily fellow trained, kind of like similar to medicine, but you really have to become an expert in that. It takes years of practice and a lot of patience and a lot of will. And so what I do as a audiologist with children is that I diagnose hearing loss in children who are maybe infants, so as little as 3 weeks old, up till age 21. And then the other part of what we do as audiologists is that we are experts in the vestibular system, and that's the other part of the inner ear. I always tell patients and parents that there's two parts to the ear. One is for hearing and one is for balance. And this contributes to things like gross motor function in children. It also can contribute to things like migraines and motion sickness, car sickness. It can be affected after concussion, as can hearing. So we kind of look at this very small organ, but this organ's really an important sensory organ for so many things in our lives: communication, physical activity, mobility. So as an audiologist, we are trained to diagnose disorders that affect both of those systems. And then we pass on those results to our colleagues, and that's typically an ENT, another physician, like I said before, all these specialists for different reasons. And then after that, we really, I hope, I hope. I know I do. I know that I help inform his medical plan or his surgical plan, right? And then afterwards, we can work together and he says, yeah, I agree, and we're going to do this. And then as an audiologist, our job is to make the function work now with whatever it is. And that's typically in the form of hearing aids, amplification. It can be as things like a surgical option like cochlear implantation and other types of devices for that. And then when it comes to the dizziness and vestibular side, we are also trained and we can be specialists more in vestibular rehabilitation along with our physical therapy colleagues.
Excellent. So we're going to talk a lot about rehabilitation too. And I love when you said too that you can diagnose hearing loss as early as 3 weeks. And that's amazing to me because sometimes we don't know what babies, because how do they tell you? And that to me, pediatrics is so interesting. It's like, how do you know what's happening if they can't tell you? Once they're of speaking age, it's like, oh, this hurts or this doesn't work. So it's going to be a really great show this evening. As an ear, nose, and throat specialist, also as a head and neck surgeon, fellow trained, et cetera, you're that guy. But what does that mean to our audience? So people who are tuned in, it's like, okay, what exactly does that mean?
So pediatric ENT or head and neck surgery is a fellow level kind of trained specialty. We're a surgical subspecialty and we take care of basically everything shoulders up is the old joke that we always say.
Okay.
Everything outside the dura where neurosurgery takes over, but above the shoulders. So we do things in the adult world like skin cancer, like oropharyngeal cancer, aerodigestive issues. We do a bunch of hearing things all the way from children to adults. A lot of general ENTs also see children, but the fellowship training in pediatric ENT is focused on kind of complex kids or traditional kids with complex needs. And so things that we offer that general trained ENTs typically don't are things like cochlear implantation for hearing restoration on kids who have very, very little, if any, hearing. Things like airway reconstruction. We are specially trained in management of tracheostomies and the aerodigestive tract for children. We also do laryngeal reinnervations where if a child has a disorder where their vocal cord doesn't work, we can help bring that back.
Okay.
Affecting voice, affecting swallow, affecting things like that.
Mm-hmm.
So we do a little bit more on top of the general, and we focus just on the pediatric population with it because their needs are a lot different than the adult population.
Absolutely. So what I'd like to do, because both of you all talked about the complex specialties and the specialties that usually are compounded within this area. So we know that El Paso Children's specifically now has this multi-specialty center. So I'd like to talk about that because, and for those people who don't know where that is, and it was so nice to explain right before the program, but the old food city that's on Paisano is now you're laughing, but we were like, that's a free plug for, somebody that likes to buy groceries. But that is the multi-specialty center, and it's right behind El Paso Children's Hospital. So when somebody has an issue, and walk me through, and Amanda, I'm just going to go to you, Dr. Amanda Chu, Dr. Mrs., let me think of how to ask this question. So what are some of the common issues that a child has that a parent comes to you with that's like, you know what, I think something's not right with my child. Can you check this out? Like what might the symptoms be? And you talked about 3 weeks to however many months, but what are some of the more common ones that we can kind of start this program out with and that we can kind of go into more specialized issues?
Sure. So I would say the majority of our referrals as an audiologist are coming in from, parents concerned about a speech delay. And so when we talk about hearing and speech, they're related in the sense of input-output, right? So especially with young children before the age of about 2 or 3, there's a critical window there into which their brains are taking in input auditorily, and they're developing speech and language as the output. And so I would say probably the most common that we share as patients as well are kiddos that are coming in who are speech delay. And there's a lot of causes for speech delay, as we always say, and hearing is just one of them. Mm-hmm. So we get a lot of kids who come in who have speech delay, and we're part of the role to say, well, let's figure out what the hearing looks like.
Right.
That's probably the most common. Now we're going to throw in a little bit of a bunder because this is what happens every single day.
And I'm going to say this too because we talked earlier about myth busting, right? So, and we're going to have fun with it, but at the same time, to make that point very clear is that it's not automatically, oh, they can't hear or they can't this, that, and the other. So that's going to kind of not be the theme of the show, but we're going to throw a lot of those out, especially because parents think that they know, but they don't until they find out what's happening. Okay, Absolutely. Excellent. So if there's speech delay, it's not necessarily the fact that they can't hear.
Absolutely. Yeah.
Okay.
So we definitely agree in kind of doing a hearing assessment. Our hospital's totally equipped to be able to test hearing in infants. So you said before, they can't raise their head when they hear the beep, right? Well, we have a lot of sophisticated equipment that allows us to do objective physiological measures of the auditory system. In fact, before the service lines of audiology and ENT came, there was no one in our community that was able to provide that level of specialized testing in infants. And what you have is now children lost to follow-up. They failed their newborn hearing screen in the hospital, and now they're 2, 3, 4. That critical window has closed.
Now, I have a question, as if I'm somebody listening at home. The newborn hearing test in the hospital.
Yep.
Tell me how that test is conducted, and how does one know if a baby can hear if there's just like everything going on? I'm curious as a parent of old people, but at the same time, when we're looking at that, just someone who doesn't see this or is around it all day, every day, how is that conducted? Yeah, so the newborn hearing screening program is universal in the United States. So every state has their own protocol, but for the most part, what we do in our hospital at least is it's what we call an auditory brainstem response test, an ABR. It's typically automated, so it's kind of a quick push of the button, and that allows for nursing staff, other staff members who are not specialized audiologists to be able to access and do this testing on all children. And what we do is put some electrodes on the forehead, behind the ears, and we play a really loud sound in the ears. It is safe for children. I know that's going to come up. It's safe, but it allows us to test the brain's pathway for hearing. So the sound goes through the ear canal, it goes through the eardrum. It assumes that the eardrum is moving well, and that sound can go to the hearing organ and then the nerve. And so we're able to sort of test how strong that pathway is by literally clicking a button and having these electrodes on. You're right, it's very contingent on all these wonderful factors playing out. The baby is still and quiet, and everyone's trained. And of course, we as audiologists are there if that child fails twice on either ear, then they come to someone like me who has more time, more expertise to be able to really determine, was it just other factors, for example, fluid behind the eardrum, very common in children, or is it something going on with the hearing organ? And so those mechanisms and those type of testing that we have access to at our hospital that we're able to do because we're experts in it has really allowed us to identify hearing loss in young kids. I mean, I'm proud to say that one of my youngest is a month old. By Texas guidelines, we have to identify hearing loss by 3, so we're ahead of the game. By 3 years?
By 3 months.
Oh, by 3 months. I was going to say hello. Okay.
But we'll take that as a win, especially in our community.
Oh, heck yeah. Absolutely.
And I think it's very important to say also that these automated hearing screens in the NICU or in before they leave the hospital are not necessarily diagnostic either. Right. So that doesn't give us very detailed information about their hearing. And before audiology was established here and Dr. Amanda Chaio was able to kind of institute this, they didn't have a diagnostic pathway afterwards. So when they come into an audiology clinic following, sometimes they can do a more detailed automated, or not automated, but an auditory brainstem response testing that gives them very specific frequency and ear-specific information that tells us which ear is not hearing and where are they not hearing and how much are they not hearing. And that really guides the treatment of us on the medical side of things in order to talk about, what do we need to do to get them hearing better? Do they need surgery? Do they just need treated medically? Do they just need time? It all kind of depends. But the diagnostic side of things, and especially with complex kids who have behavioral issues, who don't respond to all these ideal conditions when we're testing them in an automated sense, we have the ability to help with that. And a pediatric specific trained audiologist is very important in that role because they have several different tools up their sleeve to be able to help. And we can also do sedated objective hearing testing that nowhere else in town is doing that tells us, exactly where they are, especially these complex kids.
So you hit on a point too that I'd like to expand on a little bit more. And we're looking at different complexities. So hearing loss, behavioral issues. Again, throw me a case study of a child, no names, no, maybe an age, that might help, of what some of these multi-specialties are that a child is experiencing where you guys then come in, because then you're diagnosing quite a few things, correct?
Sure.
Yeah. Okay.
So there's several different multidisciplinary clinics that we're going to be as ENT and audiology starting throughout the next couple of years. The first 2 are probably aerodigestive clinic, which is where I, as an ENT, help address the upper airways, and pulmonology helps address the lower airways, and gastroenterology helps address the swallow and the GI system down low. So a lot of the complex kids have issues from birth where the aerodigestive system is kind of like one big system in there. It shares a whole bunch of lining and mucosa in the same space, and a lot of the disorders kind of relate to each other. So take, for instance, a child who's like 1 year old having difficulty gaining weight. And every time they take the bottle, they're coughing, they're choking on thin liquids and things like that. In an aerodigestive clinic, what we would do is we would each kind of see the patient. Patient comes in, gets checked in, goes into a room, and we as physicians and specialists kind of rotate through there. And each check in with the family, and they see speech therapy, they see ENT, they see pulmonology, they see GI, they see a case manager.
Same day.
All in that same day,
Nice.
on that same clinic
Okay.
appointment.
Right.
And
in the same space.
in the same
Excellent.
space. And that's important because, families otherwise having to take off, like 4 or 5 days to just see the different specialists at their appointment times.
Right.
So getting these kids in and being able to treat them in kind of a similar space and a similar environment. And like my wife always likes to say, meeting the parents where they are
Right.
and what they need is very important. And so we can kind of address these complex issues that kind of relate to each other. Audiology is going to be setting up a concussion clinic with neurosurgery as well for mild TBI. And we're going to, audiology and ENT are going to be setting up a multidisciplinary hearing loss clinic where our kids who have hearing needs and complex hearing needs, we can have them come in. They can get their vestibular testing, which, by the way,
What is that exactly? We talked about that. I hear about it all the time, and I don't want to bulldoze over that. But let's stop at vestibular testing because that's such a big deal, right? Because that affects so many different things.
It is a really big deal because there's only about 4 centers in the United States that have the ability to test and the expertise to be able to do this.
And we have one here in El Paso.
Dr. Amanda Chaio is
Amanda Chaio
is a
Very
national
nice.
and
Doing good today.
internationally known vestibular specialist.
Excellent.
So I'm talking her up, so I'll let her kind of talk about this vestibular side of things. But the next closest rotational chair is probably Denver. Houston hasn't even set up their clinic yet. And I think Denver's the closest to be able to do what she can do in her clinic here.
Okay. So now that we set you up, you can take it away from there.
Thanks for the segue. Yeah, I might be a little bit biased, and I do feel like it's a very important sensory system to look at. Like he mentioned, I've trained in this area, and again, people think it's such a small organ. Who cares?
But it affects everything.
It does. It affects, especially
everything.
in children, vestibular loss. So again, this is the other part of the organs in the inner ear that contribute to telling your body where you are in space with head movement and balance. And what the research has shown, and a lot of wonderful investigators have shown over the past probably about pretty recently, 15 years, they've really shown that when a child is born with a genetic condition that maybe they're missing these organs and they have hearing loss and they have other things, well, they are delayed in their gross motor to sit, stand, and walk.
Right.
These are kiddos that would be unsafe to put on a bike and maybe they hit their head and now we have a sequela of head trauma. So we're kind of really like learning all of these consequences of vestibular loss in children. And we know a lot about this stuff in adults, and adults fall, and everyone's like, okay. For me, I love adults, but I'm interested in kids because I really want to be able to prevent, that type
and if
of
they've
quality
never
of life.
felt being steady and they're always not steady, it's something that's not new to them. So they just, it's a lack of developing.
Yep.
And that's why I wanted to focus on it early on in the program because it affects almost everything when it comes to, when you're talking up to 3 years. I know we said 3 months ago, but up to 3 years because you're looking at crawling, scooting, crawling, and then just standing up to walk. If you're not doing that, a myth buster again, right? Say someone's not walking by a year and a half or 2 years. What is it that people are looking for? Would they think that it's the ear?
Probably not likely.
But there we goes another myth.
Definitely. And, diagnosing, we're really fortunate at El Paso Children's Hospital. We have the technology to be able to very precisely diagnose the integrity of these vestibular organs to the level that we do the hearing organs. You're talking about being able to assess this both system in the same child.
And how do you do that?
So one of the ones that we're referring to, they call it the concussion machine. And I think that's probably accurate, but it's actually it's called a vestibular rotational chair. It looks really, really terrifying, but our hospital has wrapped it in like a spaceship because that's our theme in our hospital. And every single kid that walks in there says, "Whoa, can I go in there?" And
nice.
So I know that, it's a interesting chair where they sit in it. We put some video recording goggles and we actually rotate them kind of like a roller coaster side to side. And kids love it. Adults don't, which is why I work with kids. And so they spin back and forth, and we watch their eye movements, and we're able to determine the integrity of how strong the inner ears talk to the eyes, and there's a connection there. We call it the vestibular ocular reflex pathway.
So you're watching their eye movement and finding out through the brain what's happening inside the brain, eye movement.
And that infers back to the ear. There's no way for me to open up the inner ear and look at that integrity, but I can infer it with the eye movements. And so we use video nystagmography. We call that VNG.
And are there cameras inside of this?
Yep,
this
there's cameras
capsule?
There is, and there's cameras or special goggles that, we play with the kids and we put them on. And so we're able to look at this, how strong this reflex pathway is, as well as what's called the vestibular colic reflex. This is a reflex in the neck that contributes to the spine, and that's for walking.
Wow.
So we're able to look at a lot of, and there's other measures, right? Obviously, we have to do balance tests and all those things. But we're really looking at how well can they adapt, how well calibrated is their head movements, eye movements to their inner ear and vice versa. Right. So we're able to do that. And again, back to, what Jonathan is talking about, if we have this ability to diagnose to that level, we can then take it to him or take it to physical therapists or take it to, I mentioned hem-oncology. Some of the medications that they prescribe are actually Au.D and vestibulotoxic. And so we work a lot with our hem-oncology department to say, what the drug that we're doing is starting to change.
So that is brand new to me. I would never have thought that would be a thing. Yeah. So you're looking at certain chemotherapies that do affect, and it makes sense.
And they're known. They're known to
as
affect
you're saying
it.
It out loud, it makes sense. But who would put those two together unless you say them out loud?
Exactly. And so we're able, again, to be another diagnostic side to kind of say, hey, this is changing. And will it change that maybe child's overall treatment, considering their situation? It may not. But it allows us as a team, hem-oncology, myself, maybe it's ENT, physical therapy, rehab. It allows us to have the conversation of, okay, well, let's start talking to parents about what to expect.
Exactly. And you were talking about working with adults, one thing, but in a child, things are changing so fast. It's like from 0 to, we stop growing, around 13, 14, 15, whatever it is, everybody's different. But the amount of tissue growth that happens and the speed that tissue growth happens, and I'm looking at you as a surgeon right now, right? Because you're talking about voice boxes, for the lack of a better word. You're talking about different surgeries that you can do, tracheal repairs, for example. So with all of this, I'd like to somehow incorporate what you do as a surgeon in this area. So when you're looking at, let's talk about audiology. So we're talking about the cochlear implants. When it is discovered that with all these tests, and it's amazing to me the diagnostics that you're able to make here. And I think all of us have seen videos of a child that hasn't been able to hear, and all of a sudden they have a cochlear implant and they can hear, and it's like, the whole world opens up. Physiologically, during these surgeries, and I know you've got a lot out there, but how do you do that? So again, as a layman, my little brother, I'm 57, he's 54, he had to have tubes in his ears, completely not related to hearing, but maybe yes, whatever the situation was, there are infections. But that's what I know about ear operations. My daughter had constant ear infections. She had mono when she was young. She always has tonsillitis. This is what ENT means to me because I didn't have to go through anything specialized. So now take that to what the common everyday child ear, nose, and throat doc does versus what you do in all your specialty care. Are you following kind of how I'm throwing that out there?
I think so. And
okay, so hearing loss specifically, perfect, great.
So with hearing loss, there's a wide range. So your brother needing tubes, that is on one end of the spectrum of kind of ENT care. So that's something that we do. We do ear tubes, we do tonsils, we do everything in that space as well. Ear tubes are something that can help the ear breathe through the eardrum. We all have kind of natural breathing tubes of our ears, I always tell parents, in the back of our nose called our eustachian tubes. And those eustachian tubes are developing until around age 7 to 9. And when they are maturing, they don't function as well as they do as an adult. So often we get children with recurrent ear infections or retracted eardrums or difficulty with their hearing because of that fluid behind there. And so ear tubes are indicated in a lot of these kids. But when hearing is isolated to kind of the inner ear or the cochlea, the hearing organ, that's something a lot different. There's several different reasons that can happen. Some we can offer interventions for, some there are just no interventions for. Like if their inner ear has not grown or they didn't develop it when they were growing in utero. For cochlear implants, the hearing can change over time. So we have 2-year-old that had meningitis and was in the hospital for it. He was treated, he was out of the ICU, and the pediatrics team appropriately consulted audiology for a hearing test to make sure that everything was going okay. The mom had noticed he wasn't responding as well, or things like this. Meningitis is something that causes inflammation of the inner ear and the inner ear fluid in there. And that can create scarring. It can actually turn our hearing organ, the cochlea, into bone, called labyrinthitis ossificans.
Okay.
And once it turns to bone, that's it. There's nothing we can do to restore the hearing on that side. So this child was a week out from his meningitis. We identified a profound, or the most extreme level of hearing loss on him on both sides. He was previously starting to talk. He was making sounds and stuff like that, and then he just regressed.
So meningitis wiped all of that out. That
Meningitis was starting to wipe it out, and his hearing was gone.
Okay.
His cochlea was thankfully not a bone yet, but there was scarring, especially on one side. But we were able to get him to surgery within 4 days, I think, and get him bilaterally implanted. And now he's saying "mama." He's
dancing to music.
He's
again.
dancing to music.
Wow.
So we were able to save this child's hearing like that. The surgery itself is a lot more complicated than an ear tube surgery, though.
Right. Oh, yeah. And how does the cochlea turn to bone? Is it scar tissue that's hardening it, or what is it that is happening?
Pretty much. It's
okay.
ossification from inflammation in there. So the inflammation causes a reaction in the tissue and the cells that then just basically scars off. So like if you have a scar on your body or something, it feels a little bit different, right? It's fibrotic, it's hard. That happens inside the cochlea, and then the cochlea's natural reaction is to fill that space with bone afterwards. But like even the different degrees of scarring in there can affect the hearing, and we actually notice it even before the scarring has happened. Which in this case, this child, we were able to get in there before it got scarred to the point where it was irreparable.
So you said this, but tell me the age again.
He was about 2, right?
About
2.
a little less
Okay,
than
so
2
right
years
when
of
you
age.
are, and I'm embarrassed that I don't remember. So when in a typically developing child does speech start to occur? I know it's different with everyone. I respect that. But a range.
Kind of expressively. I mean, really about 1 month, we start to see those milestones, babbling, making vocalizations. That's considered an expressive speech milestone.
Mimicking.
And then making first words about 12, 15 months.
Okay.
And this particular child, he actually was born with hearing. So the meningitis just took it out for this time. And our goal is to get in there quickly so we have less time without access, input, output, right?
Right.
So in these cases, his outcomes are a little bit different, and they're positive, thankfully, because his brain knew what sound was like.
Right, exactly.
He had kind of those
His brain knew that
milestones.
already.
Yeah.
Okay.
It's a little bit different. And I kind of want to make a little personal note. I'm from El Paso. I'm born and raised here. And I think that this case was also a really good example of how we can do audiology ENT, and we always say this, in our community. That's very different than how we would do it in other places that we have trained, and we've been really fortunate to train, great places, but to adapt your medicine and adapt your practice to this community is super different. And for this particular family, it took an orchestra. And I mentioned to a ton of people, I'm like, there's no way that in another place we could just boom, 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 get all these things. And time was critical.
Oh, sure. Yeah.
So to get to work with our hospitalist teams who, consulted us, get in there. Again, we can do sedative testing. This is a 2-year-old. He was obviously not well. He was moving a lot. I couldn't have done a traditional hearing test to know. So we were able to go into the operating room, do a sedated hearing test, like I was mentioning with Jonathan in the room. We can only do those things because we have the ability to do it.
Right.
And we were able to diagnose that hearing loss within 2 days of me saying, I have concerns. And then from there, we worked, with our surgical teams, everybody. And it was a really beautiful opportunity to kind of show, like, you can have these great outcomes, speech and language-wise, but you really kind of need to also have the people in the room who know what they're doing and who are willing to work together to get it done. And that, I think, is a really big piece to, like, that case particularly, but also I think transcends into when we expect outcomes of children of hearing loss with cochlear implants, it's all family-based.
Right.
It's support-based.
Right.
It's team-based. It's not just he puts an implant in and boom, it works.
So following that path, I would love to know, like, how long has this idea been in place? How long has the multi-specialty center been there? Because I know that when something like that is fully functioning the way it is now, it started a decade ago or 7, 8 years. How did that all work? Because I think, to your point as an El Pasoan, I think we don't give ourselves enough credit our community does not give our community enough credit. Again, in the opening, I said that because of this multi-specialty clinic, there are people that would have for other specialties have to leave town or I can do this in El Paso, but I can't do that in El Paso. And to that point too, in the opening, it's like sometimes if weeks go by in a 2-year-old, weeks are fast. I mean, it's way too much time to pass.
Absolutely.
So I don't know if either of you kind of know the building up of how the multi-specialty clinic was to come about and how long has it been around?
So we started here about a year and a half ago.
Okay.
I started in September, and my wife started in November of 2022. And at that time, my clinic was on the corner of El Paso Drive and Paisano there.
Okay.
And we had a total of 7 rooms. And we had a total of 7 rooms for all the specialties at El Paso Children's.
Wow.
And so
Okay.
we were kind of like jockeying position to try to get more patients in. But no, there's 2 other clinics running at the same time and this sort of thing. So we were really limited by space and by allowing everybody else to come in.
Mm-hmm.
So in March of this year, when we opened the multi-specialty center, we're now more than 40 rooms. I think it's like 45
Excellent.
rooms. We have
Okay.
4 separate pods where collections of physicians who kind of work similarly and share patients and work together kind of can share that space and have all that space and access to help. So how long it's been planned, I have no idea.
Yeah.
However,
Yeah.
the difference between what we started at that was 2 years, like 1.5, 2 years ago.
Which is
from when
almost
I
like
started.
yesterday in this type of situation. Yeah.
And then to actuate it in March of 2024 and to be able to, I saw 39 patients there today.
39 patients today.
Yep, 39 patients before we
Goodness.
came over here today, with
Okay.
the help of my NP and my team.
Of
They
course,
make the
yeah.
world run.
Mhm.
But like the ability to do that is really based on kind of that support and the whole team-based approach.
Yeah.
You know, and we talk about El Paso, but this is really the whole region. Like you were talking earlier, I
Yes.
mean, your specialty, Denver is the closest. So if you're looking at New Mexico, other parts of Texas, so yes, it's a rah-rah for El Paso, but it's really a rah-rah for all the people, for states and states around us as well. So kudos to El Paso Children's for doing that.
Yeah, and I think we're certainly excited to be able to have this beautiful space and to be able to walk down the hall and talk to each other. And I mean, I can get a hold of him at any point, right? I'm his wife. I can make, he has to answer.
Where's
my
the
phone calls.
banter? I keep waiting for the banter. You guys aren't throwing nuggets at each other or anything. It's
He has
like,
to
I was
answer.
waiting for that to happen.
No, the phone rings and we're like,
Well, he doesn't want to get in trouble. He was giving you praise and
Yeah.
adoration earlier.
I
It's
know.
like, she's a rock star. It's like, I know.
Um,
We were talking about too, so you were talking about 7 rooms originally,
Mhm.
and there are new specialists there. Going on, when you were talking about your team, maybe introduce to me just verbally some folks that are on the team that help you do what you do.
Oh, 100%. So my NP, Maggie Diaz, is really my right hand. She sees patients independently. She sees patients with me. She assists with patients in the hospital. She's there for my surgery. She's checking in, checking out. My schedulers, my MAs, Sandra Para, Patricia is my other one there now. And they keep my life in line and they keep the patients focused in everything. So they're the ones that are really organizing and making sure these patients are taken care of. It's very patient-centered, which is the important thing.
Yeah.
So when something is going wrong, when I'm running 2 hours behind in clinic, they're the ones that look at me and say, hey, you got to do this, you got to do this, and keep me in line with that.
It's like
And
she's your wife and they're your moms.
Exactly. No,
Okay.
100%.
yeah,
No.
we're texting like he hasn't
Yeah.
eaten today.
Oh, 100%.
What snack does he like? And I'm
And-
like, I'm busy.
Here's some cashews.
And the operating room team too. Like the operating room is a whole different environment over there. And having people that know how ENT works, how audiology works when she's doing a sedated hearing test on someone has been very important. Maya Martin Thomas is one of the ones that I work with every day. Ana Lucero is always in my OR helping me out too. And there are whole teams over there that work with me all the time. Jeannie Shaw is the manager of our operating room at peri-operating.
A lot of
I
gifts.
know.
Oh yeah. No,
I like
but
that.
like really it's the surgery is a very small part of things. Even with the cochlear implant, like my wife was saying, like the surgery for 2 of them takes about 4 or 5 hours. But that's 4 or 5 hours in this patient's now years of treatment. And it's audiology, it's speech therapy, it's the parents, it's watching out for those ear infections from the pediatrician. Like it's the team is really what makes it. And being able to do that in this center and kind of having this support and these people to kind of keep me in line to do that.
I'd like to expand on that. And both of you all bring up family. And to your point, too, being El Paso, family is everything here. And it's not that it's not everywhere else, but it really is here. Mm-hmm. On that point, because you really do, when it's pediatrics, you have to involve the caregivers. And, hopefully there's parents. Sometimes we're not lucky enough to have parents. But let's talk about the first meeting with a parent. Mm-hmm. And going through all the stuff you might have to do. So, and the reason I say that is there's a lot of mental and emotional happenings in this situation. It's my child. It's my baby. What's this mean for the rest of their life? What's this mean for the next month? Mm-hmm. Maybe go through a case study or talk to us about how the very first baby steps occur to all the stuff that's going to happen.
Yeah,
going forward.
I think we have our ideal case, right? Mm-hmm. We had another 2-year-old that was sort of lost to follow-up and maybe was misinformed about the status of their hearing. And so we're the first ones to say, there's nothing there, and you're a candidate for a cochlear implant.
Oh, wow.
And
so they had never heard this before.
Yeah.
And they're 2 years old. The child's 2 years old.
And oftentimes I'm the lucky one that gets to, share the news. But to your point, it's really important in our culture because family is everything. And a lot of times you're having to get the family equally on board to the medical plan that we as the professionals feel is appropriate. And sometimes that takes time. Sometimes you want to run and you want to say, we want to do this now. And you got to have to be patient and let that grief cycle happen for that family to be ready. This particular patient that I'm thinking about, when we were able to say, this is what we're going on, this is the plan, they were so much on board, and we were able to get this kiddo implanted and give them, what they needed, and his outcomes are definitely improving and getting there. But I think one thing that really resonated with me was just how our hospital and how kind of to Jonathan's point, it's very patient-centered, and that's a really important part of what we do. Allowing 14 different family members to be in the room when we activate the cochlear implant.
14 different family members. That's so El Paso.
That's very El Paso, right? Yes,
is.
It's very El Paso. And I have to stop and think that, there was grandma and great-grandma and cousin, and there was all these people in the room. And what a luxury it is to say you can bring anybody. But if this kiddo had to go to Dallas, they can't all travel. They can't have the money. But having all of that family support is what this child lives with every day. Mm-hmm. He stays with grandma. He, lives with cousin. Right. So it's really important that we are adapting our clinics and our practice to, and I keep harping on that, but it's just really important for what we do. Mm-hmm. Communication is incredibly crucial to culture, and our culture as a Latina, we don't shut up. We're constantly talking. That's how we show our love and how we express. Mm-hmm. And so I think that's a really important piece that I think we're trying to really develop, but really unique to El Paso. Mm-hmm. And then I think about the other patient that we were just talking about who had the meningitis, and mom had to be told he had meningitis, he's deaf. Do you want a cochlear implant in about 4 hours?
Oh, dear Lord, really?
And so you don't have that time to go through that grief cycle. You don't have that time to counsel on, this are the risks, this is what we cannot promise, this is what we can do, this is what's expected of you. It was,
so is the whole team laying this out on the table?
Yeah.
You're leading the team. You've got, again, all these assistants that are helping out. So, deer in the headlights type situations, when they have to make these decisions, how does that come about?
Yeah, I wish I wish there was a perfect recipe. And you know what? This is classical, our community too, right? It looks different for every family. I think in an ideal world, you sit around at a table and you have all the specialists. And now towards the center, we can do those types of things a little bit more. Mm-hmm. But in those moments, it just really is all boots on the ground. And I think, to your point, for that particular kiddo, it was 9:00 at night. We had made the diagnosis. Mm-hmm. Mom was in the recovery room waiting. And it was really all the OR staff, myself, Maggie, the NP. But I think that's also kind of just showing, that we're all sort of, when it comes to this type of intervention, it's a lifelong journey. That's what I tell parents.
Right.
It's not something you just turn on and turn off. It's there and you got to work at it.
Exactly.
We really lean, I think, a lot on our own sort of values of wanting to be supportive for our families.
And how human is that, right? At the end of the day, and there is, again, I've been doing this program for almost 27 years, and I don't remember which doctor said it, but at the end of the day, it's I'm just treating a human. Yes, I've got this medical, but I'm just treating the other human, and I want to be good doing it. When we talk about hearing, I want to talk to Dr. Jonathan Chaio for a little bit about some of the surgeries that you do that are not hearing related, that are not audio related, but you said earlier that you do surgeries on tracheas, on airways. Give to me some of the pediatric situations and maybe congenital versus, because I know we can go into accidents, but let's talk about stuff that may be congenital with a child that you might have to deal with.
Sure.
In your specialty.
Yeah, and a lot of ENTs will do this, but with kids, we always worry about airway foreign bodies. Something that a child has been running around with in their mouth, and then they have a coughing fit, and then there's something stuck in their trachea, their bronchus that is blocking their breathing. So that is one of the things that, honestly, almost all pediatric ENTs has had in their past that got them interested in going into pediatric.
I have a story to tell you about my son.
Oh, no.
It might be after the show, but yes.
But also what we do is there's a lot of kids in town and a lot that come actually through the NICU or transferred from other hospitals that now that kids are being born earlier and earlier and they need different life-sustaining options. Tracheostomy is something that we do a lot at this hospital.
Wow.
And complex tracheostomy care is a lot like Dr. Amanda Chow was talking about, kind of meeting the parents where they are and involving their family in it. Because basically, a child can't go home from the hospital with a breathing tube in their mouth.
When I'm talking child, we're talking a brand new itsy bitsy tiny little baby. I mean, the microsurgery, I almost picture it that way.
Well, the airway is really small at those ages.
Yeah.
The youngest I've done is 1 day old, and that was an emergency. But yeah, it is a lot smaller than the adults. And there are a lot more risk than in the adults. And having a center that kind of understands that and can talk to the family about that is very important. And we've had good support through the community and good support from the other hospitals to kind of transfer them in. And there are other kids that get transferred in where it's not necessarily that. And we have our multidisciplinary approach. I remember one where they were transferred in from another NICU after having an esophageal atresia, and that was repaired, but then the kid just wasn't doing as well as they thought. And so they got transferred in, and my pediatric surgery colleagues, Dr. William Spurbeck, who's probably been on the show before.
He has been. Last time he was here, yeah.
And then I were able to take him to the operating room. We found a tracheoesophageal fistula. We fixed that. They're working on fixing the esophageal stenosis down low from the repair site because the kid had a little bit of a leak, which happens with these things. And really kind of working with GI, pediatric surgery, and ENT to kind of like bring that kid back. And now that kid doesn't need a tracheostomy, doesn't need anything like that. But tracheostomy care is something that we do a lot here. And it's something that families are really, really involved in. We've had some great families come through here.
Oh, there's no question. I bet that. And I'm thinking, too, when you have these type of surgeries, because, and I know with Dr. Spurbeck, we were talking about different types of implants and just things that you have to do. So when you're looking at child's tissue, again, it's ever growing up until, middle teenage years. So when you are doing these kind of surgeries, how do you factor in the growth that has not occurred yet? And, because to me, that's fascinating because you have 1 year and there's an awful lot of growth that's happening. But if you had the surgery a year ago, do you have to have multiple surgeries until that child gets to full grown age where tissues aren't growing anymore? How does all that factor in the surgeries that you have to do?
So in the surgeries that I have to do, a lot of that is kind of dependent on the type because ear, nose, and throat all kind of develop differently. The ear is almost adult size. It's 95% of adult size by age 5.
Okay.
But the trachea will continue to develop as the child gets longer or the child gets taller. And so often children who have really bad tracheobronchomalacia are kind of collapsing in the airways in there. Tracheostomy is one of the things that allows us to provide them pressure at home to keep that open and to keep them breathing at home, either on a ventilator or on some high flow oxygen or something like that. But having a tracheostomy also helps stent that collapse open. But like you said, they grow. Their trachea gets longer. It gets bigger around. So any of these
put that in?
Well, we take surveillance. So I always look at the tracheostomies. I take them to the operating room and I look through their mouth down at their area, make sure they're not scarring. If they're scarring, I take it out or I can dilate it. I can do a whole bunch of stuff with that. But I also have to size it. So it's almost like their shoes, their feet are growing, you get a new pair of shoes. So for my trach kids, they get a new longer trach. They get a new bigger size trach if they're having problems with mucus plugging. They have, we can go from cuffed where they need a lot of pressure to help keep it open to cuffless where they can help speak better and it can be much more natural for them and less irritating. So yeah, these surgeries, sometimes the more complex ones sign you up for more surveillance care in the future, but that's more so the complexity of the child and the
Right.
complexity of the process that necessitated them to need that surgery rather than the surgery itself.
So going on that note, and I love it. And see, look, we're at 13 minutes already. It happens fast. On that note, so what I find and what I'm hearing is the follow-up is so vitally important. And
Oh,
so we're looking, and I guess it's different with every person, every 6 months down the line, and then the team that's brought in. So I'm assuming that there is some physical therapy that happens or speech therapy that happens. And feel free to kind of, whoever wants to take that one. I think audiology, you were talking about speech earlier too.
Yeah.
How does that work out? And there's certain ways of breathing. In general, say you have to give a surgery to someone who's 3 and now they're 10. What has happened between the age of 3 and 10? How many times do they see you? How, and again, surveillance, following up.
Yeah. And again, that depends on the type of problem or the type of issue that they're dealing with and type of surgery that they needed. For our cochlear implant patients, we really involve the whole team both before and after.
Okay.
So we have a monthly meeting where we discuss with the auditory verbal speech therapist, audiology, and ENT, all of the patients that we're coming down the line working up for cochlear implants, expectations, plans for aftercare, these sorts of things.
Okay.
And so we meet monthly on that. And then in terms of seeing the audiologist afterwards, that's on her schedule. But speech therapy is very important. That happens, I don't know how much,
So
like weekly, at
sometimes
least
twice a week.
Yeah.
Depends on
that makes sense.
situation.
Yeah.
Yeah, absolutely. Yeah.
So it just depends on the issue and the surgery itself.
Yeah.
My trach kids I like to see every 3 to 6 months. Depends how they're doing. Depends how long they've had the trach. Depends how many issues they've had.
Yeah.
I take them yearly for surveillance looks to make sure that there's no complications inside, that there's no scarring and that needs to be addressed. And I have one patient that when I was in fellowship in Houston, I was involved in placing his tracheostomy. He lives in El Paso. He had come to Houston for complex cardiac care, and we did the tracheostomy there because he was having issues with coming out of the heart surgeries. And then I'm taking care of him here now. And his airway is getting bigger. We're dilating him. I just injected him with some steroids and dilated him again. He's making noises now he wasn't able to do before and stuff like that. But for him, I'm taking, I think I see him every 3 months, and I just love seeing him. So, but he's what
I could tell just the way your body language is right now too.
Yeah, but that continuity of care really depends on kind of the problem, and kind of what they need help from us with. And we're like one day every couple month visits, but parents are doing the hard work at home.
And again, talking about the family. I want both of you all to think about something either that we haven't talked about yet or something that you want to expand on. In the meantime, what I'm going to do is talk about the specialties and the services that you guys do have at Children's Multi-Special clinic here. So we've got the allergy and behavioral health. We have brachial plexus. We had an entire show on that, which was fascinating to me. We also have cardiology, the CARES clinic that provides medical services for emotional support, cranial and facial, cystic fibrosis, dermatology, Empower program, which provides personalized dietary plans, ear, nose, and throat, which is you guys, general surgery, which is a little bit of you, neurosurgery, dear Lord, spinal bifida, urology, and vascular malformation. That's just a few of the things. And again, today we're focusing specifically on ear, nose, and throat, surgery, specialties, neck and head, and then also audiology and all the stuff that goes along with that. Now that I've gotten all that out, Dr. Amanda Chow, or Dr. Mrs. Amanda Chow, Dr. Jonathan Chow, Dr. Mr. Jonathan Chow. Again, there's no banter. People will not know that you're a married couple. You got to throw something out. Is there anything that we have not talked about that you'd like to touch base on?
I think one of the important things, especially with the hospital and these specialties that you kind of like listed here, is they're all pediatric based. So a lot of adult care can cover kids, but a lot of these, like pediatric dermatology is one of the rarest specialties to have. And for El Paso to have a pediatric dermatologist on staff at the hospital is huge. She manages the vascular malformations clinic. So she's kind of the director of that. We share a clinic together so I can see the hemangiomas that may be also in the airway and that are on the face. Pediatric urology. Like, I mean, that's specifically focused on problems of kids when they're born and that they develop over time.
We did a specific pediatric urology. It was fascinating to me. All the things that I had no idea was an issue. Yeah.
But all these are just very pediatric focused. So we're not doing adults on the side. We're not going and doing a facelift and then we're doing, a cleft palate.
Yeah.
We're actually just focused on the kids, which makes a big difference in kind of the care that kids get and kind of the environment they get that in. So I think it's much more comfortable for families and much more comfortable for the patients just having a pediatric focused area.
Without question.
Yeah. And I guess I'll kind of piggyback on that to say from kind of the family perspective, to be able to, and we've been talking about this, we're identifying these kids or putting trachs in when they're little and then they grow with you.
Right.
You get to kind of see them grow. I mean,
How can you not fall in love with them?
Yeah. I had one of the kids today that, shows up and she's taking pictures at his clinic and showing me.
Yeah.
And so it signifies, though, that, we are able to sustain these specialties. We have the longevity to say, I'm your practitioner, I'm your provider. From a family perspective, I think that's really, really meaningful. These families sometimes get bounced around. To, Dr. Chaio's point, they see this doctor and then all of a sudden they stop seeing them because something happened. So that continuity of care, being able to say, this is my pediatric ENT and I've been with him for this long, is really, really important for families. And the infrastructure in which we've created is to facilitate that. Even at the specialty center, you've got people that walk you in and escort you to your doctor, and again, going back to our culture, that's everything.
Right.
Feeling comfortable to say, I don't know where I'm going.
The navigation through it.
The parking is better. And, and being able to sort of connect and have somebody face to face and say, let me get you to where you need to go, facilitates that I want to come back and I want to come back and I love going to see them and it's not an issue. So I would say as much as we're so excited to kind of be pediatric focused, I think it's also a testament to the fact that our parents and our families feel very comfortable to stick with us while they are kids.
I like that. And so I was just looking at this nice little book here. I was hoping that there was a phone number here, and there is. So if people are listening to this right now and just have questions, and this is a program that every walk of life. So I didn't tell you this before the show, but when you go back to work, people are going to know, hey, I saw you guys last night and you mentioned my name. Isn't that great? So people who are watching and tuned into this, if they have any questions regarding children and health in general, the telephone number to call, 915-298-5444. All the specialties that we did mention. And again, we do still have a little bit of time, and I will talk about when I think about pediatric ENT, and I think the general populace may think this, you think about tonsils and adenoids, which my son had out when he was 19, but I still considered him a kid.
There you go.
But just quickly, because that is such a huge area, talk about when that is something that needs to be discussed. When does somebody really need their tonsils out? Because for us, we belabored it for years until we did it. He was... my Lord, he just was, what do you call that? Strep throat boy, just constantly, like 4 or 5 times a year, and ear infections. But talk about how kids come to you and that ends up being the thing. And the reason I'm talking about is because it's so common.
Oh, yeah.
But nobody ever talks about it because it's like, oh, yeah, they had tonsils out. Oh, okay. It's like going to the store and getting broccoli.
So tonsils being taken out is one of the most common procedures done on kids in the United States. Over 300,000 are done a year on kids in the United States. The way that we have approached tonsils has really, really changed over the past 40 years. So 1986 was a big switch. Beforehand, we used to take tonsils out just because kids had them and they were big. Nowadays, that has changed dramatically. The number one reason that tonsils are taken out of kids is for symptoms of sleep apnea. So obstructive sleep apnea as a child can lead to later on health consequences, but also they're not getting restful sleep. So they can be sleeping I always tell parents, you can be sleeping for 20 hours if you have obstructive sleep apnea, but you're waking up so many times. You're not getting rest from that. You're not going to wake up, have energy, be able to pay attention in school, be able to kind of like come home from school, have dinner with your family. That sort of thing is very important for the development of the child. So obstructive sleep apnea is one, or sometimes very loud snoring that we notice pauses in breathing and that they also have symptoms throughout the day, such as falling asleep in school, getting in trouble in school for not focusing or paying attention, coming home from school and having going right to bed, or having nighttime accidents at an age that might not be appropriate. Those are all things that relate to bad sleep. Strep is the other one that really kind of changed in 1986. And a physician, his last name was Paradise, so we call it Paradise criteria, really dictates how we take it out for strep now. And what the research says is that if you have 7 strep-positive infections in a year, you can have benefit from having your tonsils out.
That's what we were.
5 in a year for 2 or more years, or 3 a year for 3 or more years. So these like different criteria tell us, what to expect and what can we tell parents. Because without tonsils, you can still get strep.
Right.
And that's an important thing to notice and tell parents, because if you do a surgery on a child, they go through a really hard recovery for a tonsil.
Yeah.
It's a 2-week recovery. And they go through this, and then a month or 2 later, they get strep. They're like, what'd you do to my kid? So it's very important that, we understand these different nuances. Statistics tell us, yes, we'll have a 90% reduction in our strep rate. However, every child is different, and we do see the complex
and your
kids.
Immune system, you don't need to be fighting strep all the time. The reason we did it is that COVID. If he gets sick, I want to make sure he has enough of his immune system fighting all the other stuff he has to deal with. So to your point, he got it again. The first time he's like, what? But then you look into it. That was really loud. Sorry. But anyway, to your point, that was definitely there.
And a lot of what we do with the basic stuff, the tonsils and the ear tubes, is getting kids off of antibiotics, because we don't want kids on the antibiotics for the first 5 or 6 years of their life. We want them to be able to kind of go throughout life. Yes, they'll have a sore throat once in a while, but 95% of those are not strep. If they are having strep over and over and over, they're getting antibiotics every time they do it. And they need that, or it can turn into complications.
Exactly.
And there are other more rare reasons to get tonsils out, but we do those. I've probably done 7 or 8 of the more rare reasons at the Children's Hospital in the last year and a half. But yeah, tonsils are a thing.
Yeah, and adenoids. That's
adenoids
something too.
too.
I feel like when I was a kid, I didn't know what an adenoid was. And now it's like tonsils and adenoids, which I think there was a doctor once that said it's kind of like tonsils, but they're up higher and in your nose. I'm like, you have tonsils in your nose? You guys,
do.
Kind of. This is our dinner time.
This is our dinner time conversation. I kind of love that. Wait, so for those, quickly describe what an adenoid is. Yep.
Adenoid is exactly what you said. So it's a tonsillar tissue in the back of the nose. It lies on the back of the nasopharynx back there. And it grows and grows and grows, but then around puberty, it starts to get smaller and smaller and smaller and atrophy. And it should go away. In your son's case, it didn't, but around late adolescence. I've done 3 adenoids on adolescents this year because it just didn't go away.
Right. Yeah.
But when kids' noses are as small as they are, it blocks up the back of their nose. So often we see kids mouth breathing during the day. Their nose is constantly running, and they're talking like they can't move anything through their nose. Yeah. So we want to really get them breathing through their nose, because that affects their mid-face development. That affects a lot of things. Exactly. You don't want,
and they could have hearing loss.
And there you go. And hearing loss that comes back.
They also
by the audiologist.
I see all his patients.
Yeah, that's fair.
Thanks again for tuning into the show. In case you didn't get to see all the show, or if you want to watch the show or any other topic of a show that we've done in the past, there are 3 different ways that you can do that. One is through pbselpaso.org. Another one is through the El Paso County Medical Society, and that is epcms.com. And then also good old-fashioned YouTube, that I feel like you can almost find everything on there, but it's youtube.com, and then just go to the word The El Paso Physician. And all of these, you can find the El Paso Physician on there. And access any one of those programs at any time, and we will see you soon. I'm Catherine Berg, and this has been the El Paso Physician.